Welcome. Ladies and gentlemen, distinguished guests to this audience, Professor Nunes, I have the pleasure to introduce you to our WMA session within the 14th World Conference. I said already it has become a tradition that we at the World Medical Association cooperate with this conference, and we have used this stage to discuss with you, the audience, some of our most important projects on policies which we had over the past years. It has been the Declaration of Helsinki in its last revision of 2013. It has been our Declaration of Taipei on databases and biobanks from 2016. It has been the Declaration of Geneva, the modern version, so to speak, of the Hippocratic Oath in 2017. And we are now up at the World Medical Association to revise a document that is actually a supplement to the Declaration of Geneva, the International Code of Medical Ethics. Created in 1949, 1 year after the Declaration of Geneva, the International Code gives a deontological rule set to every physician globally. It has become the blueprint for many of national deontologies, codes of practice, although with certainly a number of variations, extensions, and far more details. Nevertheless, it has been an important document, but it has come to age. And certainly, points of view have changed, methods have changed, technology has changed, and our views about patients, autonomy, fairness, justice has changed as well. I'm not sure whether it has changed principles, but certainly it has made it necessary, like with the Declaration of Geneva, to look into the International Code of Medical Ethics. And for that, the idea was to give you an insight into the work we are doing currently in revising this code, hopefully to discuss with you, and maybe to get some input from you as well, some ideas, some concerns, suggestions. We have an overview and giving you an introduction, insight into this process by our council member, Dr. Ramin Parsa-Parsi, who is at the same time the chair of the working group leading the work on the revision of the International Code of Medical Ethics. He is the head of the Department for International Affairs at the German Medical Association, and he has a long experience with the World Medical Association in leading work groups, for instance, on some of the important policies which we have just discussed, like the Declaration of Helsinki or the Declaration of Geneva. So I'm proud to present to you Dr. Ramin Parsa-Parsi, doctor with a training in internal medicine, and as I said, like me, from Germany. Ramin, the stage is yours.
Thank you so much, Ottmar, for the kind introduction. And again, thank you, Professor Nunes, and all the organizers for inviting us to this beautiful town and for letting us be part of this conference. I really appreciate it. I've already learned a lot, and I'm looking forward to the next few days. And we appreciate the opportunity to present the International Code of Medical Ethics here today at this meeting. And as Dr. Kloiber said, we are looking forward to a very fruitful discussion with you guys, and hopefully we get new inspiration and further input into the process. Dr. Kloiber has already said a few words about the World Medical Association, and let me just say that it is indeed one of the core issues, one of the core tasks and mission of the World Medical Association to ensure the highest possible standard of medical ethics. The WMA was founded in 1947 in Paris. It was right after the World War II. Today it represents more than 9 million physicians worldwide and about 115 national medical associations are its members. And it truly serves as a global voice for physicians. Now, Dr. Kloiber already mentioned some of these declarations that I put here on the screen, and they certainly look familiar to you, I would guess. The Declaration of Geneva, the Physicians' Pledge, which was recently revised as well. The Declaration of Helsinki, which are guidelines on research involving human subjects. These two are probably the most known declarations of the WMA. But there's so many more. The Declaration of Tokyo regarding guidelines for physicians concerning torture. The Declaration of Lisbon regarding patient rights. Or the Declaration of Taipei regarding health databases and biobanks. But what about the International Code of Medical Ethics? And I would like to ask you a very honest and frank question, and I would like to get your honest and very frank answer. Who didn't know about this declaration, of this code, before you attended the conference or even came into this room? Who didn't hear about it or is not really familiar with its content? Please raise your hand. All right, I can see a couple of hands, and some might be too shy. Don't be shy, because it's, I think, not that uncommon that not many people know about it. But this will certainly change. Now, let me see. I know you like questions. I ask another question to see if you actually listened to the first one. Who would like to learn more about the International Code of Medical Ethics? Please raise your hand. All right, I can't see all the hands, so all right, very good. And I promise you that at the end of the conference, and probably at the next one we will have in this setting, I hope everyone has heard about it. And this is also one of the aims of this whole endeavor of revising the International Code of Medical Ethics, not only to bring it up to date, but also to make it much more visible than it is right now. And to differentiate it, but also make clear the objectives and claims from those, especially those 3 core documents of the WMA, I would like to say a few more words about the other documents. The Declaration of Geneva. It's really a pledge which outlines the basic ethical principles for physicians. It's very comprehensive, but still short enough to serve as a pledge. So that's the general core document which is supposed to be pledged by physicians when entering the medical profession. And then for the research side, we have the Declaration of Helsinki. I think almost everyone in this room is familiar with that document. These are ethical principles for medical research involving human subjects. And then for the more clinical part, there is the International Code of Medical Ethics. It's a foundation of ethical principles defining professional duties of physicians. It is, in 1948 it was, when the Declaration of Geneva was actually adopted by the General Assembly of the World Medical Association. The Council appointed a study committee to develop the International Code of Medical Ethics. It was all still in light of the report on war crimes in medicine right after World War II. After 1 year, it was then adopted in 1949 by the Third General Assembly of the WMA in London. And today we all know the DOG really works as a standalone document. But just as the Secretary General already said, the ICOME has always been presented in conjunction with the Declaration of Geneva. So even though the ICOME is a powerful document with great potential in its own right, it has never achieved the same level of exposure or recognition as the Declaration of Geneva. So that's why it's no surprise that not many people know about it. But again, this is going to change. The ICOME has been revised a couple of times, most recently in 2006 in South Africa in Pilanesberg. Now, as most of WMA documents are being revised almost every 10 years, if needed, so maybe even earlier. This is also true with the ICOME, especially after we had revised the Declaration of Geneva. We also looked into the ICOME, and the Council decided that it's time to revise it, and the Council installed a truly international work group. And as you can see, we have members from all continents of this world, and for a WMA work group, this is really a large work group, which we almost never had before. We have delegations from Australia, Brazil, Germany, Japan, South Africa, the US, Nigeria, UK, Denmark, and Kuwait. And in addition to that, we have many observers which are as much involved and contribute as much, at least, from China, Sweden, France, Italy, Netherlands, Norway, and then even international bodies such as the ICRC or the Standing Committee of European Doctors. And we are very grateful, and I have to say I'm personally very proud that this work group works so efficiently and so effectively together, always in very good spirit, and everyone is being heard. And I must say, even though it's quite a challenging work, considering the difficult individual topics we have to tackle, it works pretty well. And we came a long way until today. What the work group did right in the beginning, we decided that the tone of the Declaration of Geneva and the International Code of Medical Ethics, they should reflect their different purposes, right? Any contradiction with the DOG should be avoided, and the compatibility must be ensured. The ICOME should cover all basic principles, but not go into many details, because otherwise we would have an entire book, or maybe even 2 or 3 books. It should have a normative and not a descriptive character. Again, it should be comprehensive, but it can't cover all the WMA policies. And as you know, there's so many of them. There's literally no topic that WMA didn't approve a document on, a policy on. So not all the policies can be included, but it should be still comprehensive. So this is really a challenging task, and the work group is doing a great job to do the right selection. And also, if you read the document as a whole, sometimes it is still covered, even if the topic is not directly mentioned. But now, the most important and probably also the most challenging aspect was and is that it has to be applicable to different cultures and political systems. And there you can imagine that we spend a lot of time to find the right wording, to find the right notion, the right sensitivity, to find the right words. But we are on a very good way there. So what we did, we really looked into all the responsibilities and interactions between the physician on one side and then the patient on the other, the physician and the physician themselves, the physician and society, the physician and the profession itself, and this time, for the first time also, the physician and the responsibilities within organized medicine. What we did so far is we added a new preamble. So we looked at the structure and we thought there needs to be a couple of editorial and structural changes in addition to the content changes. So we added a new preamble, and then we have a section with general principles, followed probably by the most important section, the duties to the patient, followed by duties to other physicians and health professionals, duties to the society, and, as I mentioned, an entire new section on physicians' duties as a member of professional medical organizations. What we also did, similar to the Declaration of Geneva, we introduced a new modernized language, which is also, of course, much more gender inclusive. Now, I've listed here a couple of the issues and topics that were intensely discussed in the work group and amended. The ICME was amended. These were added. First of all, of course, patient autonomy. This is a topic, this is an issue that had been added to the Declaration of Geneva as well. And of course, we had to add it here as well in the International Code of Medical Ethics. The issue of physician well-being, which has also been recently added to the DOG and which also gathered probably the most attention and most appreciation also by the professional medical community. We added it here as well. Issues like remote treatment, which becomes more and more important, especially if we look at the past 2 years during the pandemic. But then what was very close to our hearts was the equity in healthcare and health-related justice. We have a very comprehensive language on that, but also environmental sustainability. The collaboration with other healthcare professionals, patient confidentiality, and, as I mentioned, responsibilities of physicians within organized medicine. Now, those topics which were most controversially discussed were issues around informed consent. And that's also part of the reason why we will also present that here during this meeting by the following two speakers to get your input on that as well. Or the issue on advertising and social media, also one of the paragraphs that had been intensely discussed. But here it comes, the most controversially discussed paragraph was and is indeed the paragraph on conscientious objection. As you can imagine, there are very different views around the world, and we had found a good wording, which has been revised at least 5 times already in the work group, and it will probably change again. I put it here on the screen. You don't need to read it right now, because this is most probably not the final one. The WMA Council has decided this is so important and this is so interesting to look further into. That's why the WMA will hold a dedicated international conference to just discuss this topic. This will most probably happen sometime this year if the pandemic allows us to do so. We hope to hold it in July, and we'll be happy to let everyone know once the dates and the location are set. I had wished to give you this piece of information here today, but unfortunately we don't have the final dates yet, so I ask for your patience on that, but I'd like to see some of you at that conference. I think it will be very interesting. So again, no need to learn this, no need to really start discussing this, although we would like to get your input on this, okay? We will have also, I think Dr. Kloiber is going to mention this during his presentation, and of course we would like to get your input on this, but please, this is not the final version. I would like to mention that again. Now, where are we right now during this entire process? We started in 2019. That's when the work group was installed. We started with a list of priorities and a pretty comprehensive internal consultation. Then in 2020, we started with a couple of regional conferences. And we had a really good one in Kuwait City in Kuwait, and one in Sao Paulo in Brazil for the South American region. And we had a great start of the year in 2020. You can imagine that this has been in January and February, and then boom, we had to stop our plans. We had some really nice plans for the entire year, but we had to cancel all the other conferences we had envisioned, but they were not canceled altogether. We hopefully will hold them soon. They were only postponed. So in 2021, we couldn't really hold them as well, but we had a very good public consultation. We put the document online, and basically everyone could comment on it. We had a lot of input from you guys, from the international expert community, from all the stakeholders. It was immensely successful. We got a lot of good comments, and we used all these comments to basically completely revise the declaration again, the code again. And we once again solicited comments from the WMA member organizations. So it was a pretty active year, the year 2020, even though we couldn't hold international conferences. Now, in this year, 2022, as I mentioned, we will have the Conscientious Objection Conference, hopefully in July. We will hold the other regional conferences, which we were hoping for in 2020, one for the African region, one for the Asian region, and then we will also have a final enlarged work group meeting in the US for the North American region in Washington, DC in August of this year. We will also be present at international bioethic conferences, such as this one, to discuss it with you. This was very important for us to be here today, and again, I would like to thank Professor Núñez and the organizers that we can actually hold this conference. There will be another conference later this year from the International Association of Bioethics. We will also have a dedicated WMA meeting there on this topic. And then there will be a final circulation among WMA members and a little bit of fine-tuning, and then hopefully by October we're done with the work. And we will ask the WMA General Assembly to approve it. If it all goes according to our plans and everything, but that's what we had envisioned, and we still hope that this was going to work out. I would be extremely thrilled if this works out, because the WMA General Assembly will be held at my home city in Berlin. So I would love to see you all there, and hopefully we will have a new international code of medical ethics. Now, I guess you all agree physicians face unprecedented challenges today. We have a changing political and legal market forces. At the same time, the medical profession is becoming more and more dynamic and more global. It has to become that way. That's why it's even more crucial to reaffirm the fundamental and universal principles of medical ethics. We truly believe that the Declaration of Geneva and the International Code of Medical Ethics reflect the fundamental and universal principles of medical ethics, and they will help to strengthen the professional identity and adherence to professional ethics. So thanks again, and I'm looking forward to the rest of the project, the revision of the code, and I'm looking forward to a lot of good input from you today and during the next few months. Thank you so much.
Thank you very much, Ramin. If there are some direct questions concerning the understanding of this, I would like to entertain them. Otherwise, we will have a discussion about the whole of it later on. There is one in the back, the gentleman.
Hello, Kevin de Sabata.
Just a second, there comes a microphone.
Okay. Hello, Kevin de Sabata.
Please go on.
Okay, hello, Kevin de Sabata, Keele University, UK. Among the themes that you have cited, for me there is one obvious one that is absent, which is the pandemics and post-pandemic ethics, which I'm sure you will agree with me, it's not just a matter of public health ethics, but it's also a question of medical ethics, because of course we had overburdening in hospitals, we have consent to vaccinations, we have some aspects also of containment strategies that impact. I was wondering why it wasn't included, whether there are thoughts about broadening the scope of the revision to that, or if simply that theme is scattered throughout the revisions and not concentrated in one specific title or chapter or paragraph. Thank you.
May I respond directly?
Please go ahead, Armin.
Thank you. And thank you so much for the question. I completely understand. It makes a lot of sense to ask that. First of all, the list is, of course, not comprehensive. I only selected a few which I thought might be interesting to you. And it was a very interesting time to have this revision during the pandemic. So we didn't include a very specific paragraph dealing with pandemics. But one of the major objectives, which I also actually put on one of the on the slides, is that we have to read the document in its entirety. We can't just read one paragraph, so they're all interlinked. And if you read the entire code, you see that actually everything is in the code that a physician needs to know, needs to observe, needs to adhere to, even in times of pandemic. So we didn't see any need to add a specific paragraph on pandemic situations, even though, of course, it's an interesting topic, and WMA has policy papers on that, of course, but again, we cannot include every single topic as an additional paragraph, but we think the ISO-ME is comprehensive the way it is and covers such situations very well.
Thank you, Ramin. I think we will have you back for the general discussion. There is a lady, so a second one, please, but then we will continue. Yes, please go ahead.
Thank you so much for this short presentation. In continuation with his comments, it is my question that it is not the pandemic per se. I think we need some guidance on disaster management and public health ethics. Today it is pandemic, tomorrow it may be something else. So instead of focusing on one area, can there be a broader aspect of disaster management, ethics and disastrous situation, and to some extent public health ethics? Thank you.
Thank you, and again, very good question. Now I understand, and actually we have covered that, but we can also discuss if you think this should be even covered more. But especially when it comes to emergency situations and also this kind of specific disastrous situations, we have some language in there. We can always look into it and see if we want to flesh that out. I'm happy to take that to the work group.
Thank you, Ramin.
Thank you.
As Ramin has pointed out, during this discussion, a number of items came up which have been very controversial. We will not be able to go into details for all those points, at least not in this session. Some of those controversies actually you'll find during the conference in the diverse sections of this conference, reflected or in parallel being dealt with. And that is where we like to hear and listen and also learn from that. Thomas, who will speak after me, and myself, we have taken up to look into two specific items of this discussion. And the one I have been assigned to are the questions around conscientious objection. And here, especially the question, are there limits to conscientious objection? There's a question mark behind it. I'm not sure who has put it behind it, if I was that myself or not. At least now I would like to take it away. And I would like to make it a statement. But first, let me say, as Ramin said, there is a discussion going on, a revision process, a very structured process. And part of this is, of course, also this item that is being discussed and will be discussed, and maybe even in a conference during the summer, hopefully, that we can come together again and discuss this item in depth. So this presentation is based, as far as I can, on the policy which we have, but nevertheless, it is not supposed to preclude this discussion, nor does it here bring you an official position of the World Medical Association. It is my personal opinion which I'm going to present to you here. So please take that as an individual presentation and not the presentation of the Secretary General of the World Medical Association explaining an already existing policy to you. And I declare no conflict of interest for this presentation. So let me start with what I believe conscientious objection is. To me, it is a necessary tool to execute medical work with conscience. Why that is important, I come back later. And it is necessary to allow a diversity of opinions in a society, in a profession, but also between patients and professionals. And it can safeguard against unethical practices. To me, that makes it also an important tool in the protection of patients. The issue of conscientious objection, if you look into the literature, of course, pops up in the first place in questions of abortion, euthanasia, and physician-assisted suicide. But it is also connected and described in questions of sterilization, especially forced sterilizations, torture, and other inhuman and degrading treatments, the futility of care, male circumcision, for instance, gender modifications, body enhancements, down to things like mutilations, which sometimes people want physicians to practice on them, fetal discrimination, for instance, for sex, for gender determination here, sex determination here, cesarean sections as a preference is one of those issues. Economic reasons, I think certainly the big bulk of problems that colleagues face around the world when taking decisions for their patients or being forced to work in a certain way that is more economic or saving resources rather than doing what he or she as a physician believes is best practice. A strong prescription by guidelines, but also legal requirements in contradiction, that are in contradiction to medical ethics. So is there a right to conscientious objection? That is a first question which I would like to answer from my position, but also the position of the World Medical Association. And the answer is very clear, because in the Declaration of Geneva, it says, I will practice my profession with conscience and dignity and in accordance with good medical practice. Now, an obligation to provide medical services with conscience without the opportunity of conscientious objection, to me, absolutely makes no sense. It would be absolutely ridiculous to ask to exercise with conscience if the conscience cannot be exercised. So the question is it then described in the International Code of Medical Ethics? Up to now, no, it is not. And I cannot give you the reasons for that because I was simply not present in 1949 when it was drafted. But I think my first approach was that they wanted to concentrate really on obligations to the physician in this code and not on rights. And vice versa, you could also answer, well, if you ask for conscientious objections must be an option to exercise this. However, there are documents, policies in the World Medical Association which reflect on that. One example here is from the Declaration of Helsinki, which deals with the conduct in research. And it says, it is the duty of the physician to promote and safeguard the health, well-being, and rights of patients, including those who are involved in medical research. The physician's knowledge and conscience are dedicated to the fulfillment of this duty. Now here, the conscience is seen as a safeguard for the patient or for the subject in research, which then also means conscientious objections may serve as such a safeguard. In the Declaration of Malta on hunger strikers, again, it says, if a physician is unable for reasons of conscience, conscientious objections, to abide by a hunger striker's refusal of treatment or artificial feeding, the physician should make this clear at the outset and must be sure to refer the hunger striker to another physician who is willing to abide by the hunger striker's refusal. So a rejection of a treatment or a treatment offered by a patient also has to be accepted. That can, of course, lead to the situation in a hunger strike, for instance, that a patient will die as a matter of his own will, and the physician is forced not to interact, not to have a force feeding the patient there. And that indeed can be a severe problem for a physician not to act, and the physician then has to refrain himself from this treatment and from this physician-patient interaction, and has to advise to seek another physician to work with the hunger striker. This is an extreme scenario. In most of the scenarios, it does not exist because hunger strikers usually don't want to die. They want to reach an aim. And therefore, this is a very extreme situation here, especially for the moment that a person gets unconscious. The objection or the consciousness is also coming into the Lisbon Declaration on the Rights of a Patient. While a physician should always act according to his or her conscience and always in the best interest of the patient, equal effort must be made to guarantee patient autonomy and justice. And here comes already a balance in there, that there is something on the other side that may be in conflict with what is conscious. And this is being set here in an equal proportion. So there is not one trumps over the other. That is very important to understand from this phrase here. And certainly the classical example is the one on the medical indicated termination of pregnancy. And there it gives clearly an allowance, a permission to exercise conscientious objections, but it says at the end, in all cases, physicians must perform those procedures necessary to save the woman's life, to prevent serious injury to her health. That is kind of already a bottom line that is being set, which I would like to reflect on a little bit further. Now, there are certainly a number of other values and principles which are balanced against that, and I come back to the Declaration of Geneva in its last version from 2017. And there is the pledge to serve humanity. There is being the patient to be the first consideration, and there is the respect for autonomy and dignity of the patient, and I will maintain utmost respect for human life. So important factors which set into a canon, which are not necessarily subordinate to each other, which have to be observed together there. Now, you probably all know the spectrum in the discussion of conscientious objection is very wide. And I give you two of the obvious ends right now. One is a quote from Wesley Smith, a conservative lawyer from the United States. He says, "The more elective the desired intervention, the greater should be the right to medical conscience." So he sees a continuum away from an emergency to an elective procedure where the possibility for exercising conscientious objections is growing with that continuum. On the other hand, you have some very apodictive statements which came up in the past years. For instance, this one here from Mr. Savulescu saying, and I quote, "If people are not prepared to offer legally permitted, efficient and beneficial care to a patient because it conflicts with their values, they should not be doctors." Very apodictive. And a similar one comes from Coughlin and Dickens. "Physicians who feel entitled to subordinate their patients' desire for well-being to the service of their own personal morality or conscience should not practice clinical medicine." Very extreme positions here in the end, and I think it is up to us to find the way there through and finding the truth on what we believe is the right ethical approach to that. There are, and that is what I constantly see, a number of misconceptions coming with that I think we have to answer and have to address. Number one is the belief very often that I hear in discussion is that a physician must treat all patients. And my answer is no. Physicians don't give up their own human rights, their own personality, their own relations when they become physicians. That's simply not true. Usually, treating a person, a patient, is a matter of a contract between the person and the physician or the organization the physician works for instance, a hospital or a health maintenance organization. And this regulates who has to be treated and who has not to be treated. So it's not that a physician has to see all patients, and we could not do this. In many cases, you will know that you have a limited amount of time, you have a limited amount of knowledge and capabilities of treating all patients. So there are limits to that. And there is also your personal choice on how much you work, when you go into retirement, whether you're working part-time, and so on. So this flat statement, physicians must treat all patients, is not true. It is usually then bound by the system you are in. In every situation, certainly not. There are situations where you can't treat. Under very certain circumstances, for instance, now in war, what we have, nobody is forced to bring himself in danger. And when you have the threat of being killed in a situation, you don't have to do that. And violent patients, for instance, may also lead to the fact that you have to refrain from a treatment, and that is justified. With all their needs and all their desires, as the author said, which I quoted before, no, certainly not. There are desires and needs which don't have to be satisfied by a physician. Some of the things patients have to take care of themselves. Some have to be referred to others or should be referred to others. And this flat statement that we sometimes hear is also certainly not correct. Everything that the law allows is morally not objectable. The idea, which also is in one of the quotes which I have given you, definitely not. That is something that we very clearly must say. Simply because something is legal, it does by no means automatically mean that it is ethical as well. That has different reasons, of course, because some of the laws don't look for the ethical questions. Some of the laws are not made by ethical people. Think of it that only half of our governments in this world are elected, whatever the term elected means. And certainly we have seen situations where governments have forced and still are forcing doctors to do a lot of unethical things. So this apodictive phrase, which was in this quote, certainly is not correct. And then finally, something I read sometimes in letters which people write to me and say, you have said there is the Declaration of Geneva and a physician must pledge, I will respect the autonomy and dignity of my patient. So the doctor has to kill me if I tell him I want to die. No, sorry. Autonomy is your autonomy about your own deeds, about your own beliefs. But it does not mean that your autonomy allows you to direct somebody else to do something or to force or to command him or her to do so. So let me conclude. I think the conscientious objections needs limits. There is no doubt in it. But conscientious objection is no fool's right. It does not mean you can do what you want and can say no to what you want. It does neither trump truth nor science. Very important for all those who think because they have a medical license that they can tell patients that vaccinations are evil, that you will get a chip implanted, or that it is all only a make-up by the pharmaceutical industry. No, it is not a fool's right. It does not give the physician the right to impose his or her conviction on someone else. You may have your beliefs, yes, and they may lead to conscious decisions, but that does not mean that you can enforce them onto others. But in exercising conscientious objection, the objection cannot override the general obligation to help to alleviate illness or any other medical condition, especially if there is a threat for life or serious medical damage. Which means there are situations where, as a physician, you have to help, regardless whether you do not want to treat that patient, do not want to exercise a certain treatment. If that is medically necessary at this moment in time and nobody else can do it, and you are capable of doing it, you have to do it. And finally, let me say, I believe that a clear limit of conscientious objection would allow to sanction the use and abuse of conscientious objection, which would mean that we get a very clear guidelines, not only for physicians, but also to them who have to supervise them. And with that, I would like to close. Thank you very much. And I'm happy to entertain questions if there are questions of understanding right now. Otherwise, we go into the discussion after the last contribution. So I don't see that. Oh, there is one. Please go ahead. Can we have a microphone?
Oh, okay. Thank you very much. That was very, very interesting. The way this is couched, though, is it responds to instances where there's an affirmative duty to the physician to act. And this couch that the physician does not have to act. What happens when there are circumstances where the physician is being told not to act? So, for example, in the states right now, there are at least 2 states that are saying that a physician cannot counsel potential trans children, I'm not even talking about adults, against entering into that puberty blocking, later on more invasive procedures. And the physician has the conscientiousness or the desire to counsel against trans, and which is not even a religiously motivated issue. So, for example, abortion might be religiously motivated. The trans situation is totally amorphous of any structural.
Would you please tell us what you mean with the trans situation?
Well, there are 2 states now in the states that are making it illegal for a physician to counsel a potential patient about the dangers of entering into the trans process. And what happens if the physician says, it's my sincere belief that I need to warn that patient, duty to warn the potential dangers of the process?
Yeah. This would not be contradicted by the statement I have given, because it does not endanger the patient, that there is no absolute need for a specific treatment to be done. So the doctor would be free to exercise his conscientious objection by telling positively. A similar incident was when in Florida, for instance, pediatricians and family physicians were banned from talking to parents about the dangers of having firearms in their household, because, you know, a lot of children killed themselves with the firearms of their parents. And then there was a law which would say you are not allowed to talk to the parents. Yes, of course you are. That is part of the conscientious objection, to exercise your profession with conscience.
Thank you very much.
Very clearly. And the second one down here.
Thank you. I would like to ask you, what measures, in your opinion, should be envisaged in the event that the broad appeal to consensus objection, it makes difficult or impossible to guarantee the patient's right to the intervention, to the service, for the broad appeal, when the appeal to conscious objection by doctor is too broad, and what measures to guarantee the intervention?
Again, here we are looking on the obligation to provide medical interventions for medical needs that are clearly necessary. There may be a situation where you have questions, for instance, providing euthanasia.
For abortion.
Or abortion, which
or
are...
euthanasia
yes,
too, in the context in which
that may indeed
was
happen.
legalized.
That may become very difficult, yes. But again, then a pregnancy is not an illness. That is
No?
very clear. A pregnancy may be a danger to the mother. As I said before, physicians have to act then. And if it is necessary to perform an abortion, the abortion has to be performed. There would be no conscientious objection against that, or not valid against that, as the already existing guideline says. Yes.
It depends on legal provision in different contexts.
No, I don't think so. I mean, you find in every country certainly physicians who are willing to perform abortions, but it leaves it open to those who believe that they should not perform abortions, at least not when it is not medically necessary, then not to perform this abortion. Yes.
Thank you.
There is one last one, and then I would say we continue with the presentation, and we will have more time for discussion in the afterwards. The lady over there, yes, thank you.
Thank you. Good afternoon. Do you think there's a way to reduce the bias from oneself's prejudices in the care of people? What I mean is, how do we not let consciousness objection affect how we treat specific groups of people, or how to reduce this bias? Did I make it clear?
Yes.
How do we protect the patients?
Yeah.
The most vulnerable ones.
There is a statement in our Declaration of Geneva and in the International Code of Medical Ethics which does not allow the types of discrimination which you are mentioning. And this is the one which you have to then discipline a physician under those rules. I don't think there is a chance to do this vice versa in the conscientious objection. A conscientious objection against that for a treatment that is necessary would not be allowed under this. And it would violate at the same time the Declaration of Geneva and the International Code of Medical Ethics. So this is something that has to be solved on the basis of the International Code or the National Code of Medical Ethics, which we strongly suggest has to exclude such types of discrimination. For instance, against another nationality, another race, or against, for instance, sexual behavior. So that is very clear, but that is regulated by the basic codes. Thank you very much. I will go back to my place. And I have the pleasure to introduce Thomas Hedmark. Thomas is a colleague from the Swedish Medical Association. He is the legal advisor of the Swedish Medical Association, and he is also the secretary of the Swedish Medical Association's Ethics Committee. He previously worked at the Swedish Medical Responsibility Board and is a member of the WMA working group revising the International Code of Medical Ethics, and I can add that Thomas has been helpful in many of our policy developments over the past decades. Thank you. Thomas.
Thank you, Dr. Kloiber. Good afternoon, everyone. As we've heard, the revision process of the ICOME is an opportunity to consider whether some issues should be introduced or addressed more extensively in a new version of the code. I will address a couple of issues where there are proposed additions and changes to the existing version. The issues I will highlight are conflicts of interest, physician advertising, and the physician's obligation to share knowledge. And hopefully, this will give you some insight into how the working group has gone about its work on this issue, in the revision process. I will start with the issues of conflict of interest and physician advertising. These issues are both separate, but also somewhat connected in that they both have something to do with patient trust in physicians and in healthcare. The WMA Declaration of Geneva, the physician's pledge, states that the health and well-being of my patient will be my first consideration, a truly basic ethical principle for physicians. The physician's task is to care for the patient and provide advice and medical treatment in accordance with good medical practice. The patient's health should come first and other considerations second. In order for the physician to be able to provide the best possible care to his and her patients, a good patient-physician relationship is necessary. If this relationship is not good, then the patient might feel uncomfortable sharing sensitive but important information with the physician. The patient might feel less inclined to trust and follow the physician's advice. And worst case scenario is that the patient even hesitates seeking health care at all. So the patient needs to feel that he and she can really rely on the physician, that the physician really puts the interest of patient first. So trust is essential. So how to achieve trust then? Well, there are of course a lot of things you can do to build trust. Empathy, professional competence, and how you talk to and listen to a person. But one thing I think is important when it comes to building patient trust is physician autonomy. When recommending treatment, the physician must be able and allowed to make independent decisions based on what is best for the patient. That is, treatment recommendations should be based on the physician's expertise and experience and on good medical practice, without any undue outside influence. The patient must be confident that the physician's advice really is based on what is best for the patient and not influenced by other considerations or interests that the physician might have. So conflicts of interest definitely need to be considered and addressed. These conflicts of interest can, of course, present themselves in many different kinds of situations. If the physician prescribing medication has connections to a pharmaceutical company, for instance, or if the physician participates in research and wants his or her patients to be research subjects, or in military or custodial settings where the physician's superiors may try to pressure the physician into putting other interests before what is best for the patient. Another situation is when legislation obliges the physician to report patients to different authorities. In Sweden, for instance, physicians must report to relevant authorities if a patient is unfit for medical reasons to drive a car or possess a firearm. As a general rule, in all situations of conflict of interest, I would like to quote from the WMA statement on conflict of interest, which again says that the primary obligation of the individual physician continues to be the health and well-being of his or her patients, and that other interests must not be allowed to influence clinical decision-making. So once again, the patient should come first. Another important thing is, of course, to actually acknowledge that there is a conflict of interest, because if this is not recognized, the issue will not be addressed and resolved. The WMA has currently several separate policies addressing conflict of interest intended to provide guidance to physicians. There is the general WMA statement on conflicts of interest that I just mentioned, and there is also the well-known Declaration of Helsinki regarding research involving human subjects, and also policies dealing with relationships with commercial enterprises and obligations in times of armed conflicts. But how about the International Code of Medical Ethics? This is the policy containing or aiming to contain the basic ethical rules for physicians. So what does the ICOME say regarding conflicts of interest? Well, the current version specifically points out that the physician shall, first of all, act in the patient's best interest when providing medical care. So again, the patient's interest should be at the forefront. The ICME also says that physicians should exercise independent professional judgment and be dedicated to providing competent medical service in full professional and moral independence. So the independence and autonomy of physicians is emphasized. This helps protect the patient from external irrelevant considerations. The ICME also stresses that the physician must not let his or her judgment be influenced by personal profit and not receive any financial benefits or other incentives solely for referring patients or prescribing products. This wording deals with the patient's interest versus the mainly economic interests of the physician and other stakeholders. The ICME stresses that such economic interests should not be allowed to influence the physician's decision. Finally, the ICME says that when the physician is acting for a third party, the physician should ensure that the patient has full knowledge of this situation. This wording is maybe a little bit unclear, at least to me, but I suppose it kind of addresses the situation and the need for physicians to declare conflicts of interest in some situations. The draft revised ICOME, of course, keeps many of the principles in the current version. It talks about offering care in the patient's best interest and about exercising independent professional judgment. But the draft also clarifies a couple of points. One paragraph in the section of general principles is specifically devoted to conflicts of interest. It says that physicians must not allow their individual professional judgment be influenced by the possibility of benefit to themselves or their institution. It is clarified that not only potential benefit to themselves, but also to their institution must be considered. The institution can be, for instance, the hospital, the research institution, or the pharmaceutical company where the physician is employed. Then the paragraph goes on to say that the physician must recognize and avoid real and potential conflicts of interest. So first of all, the term conflict of interest is introduced into the ICOME, which I think is a good idea. This is a central concept and as such should be addressed directly. Secondly, the paragraph emphasizes that the physician must recognize conflicts of interest. This means that the physician needs to be mindful of conflicting interests. If the conflict is not identified, then it can be addressed. Thirdly, the paragraph clarifies that not only obvious actual conflicts of interest should be considered, but also situations that could potentially constitute such conflicts. Perhaps a situation could be perceived from the outside as a conflict of interest. The way I see it, this wording is meant as a reminder to physicians that they need to be observant and aware that some situations could be perceived as a conflict of interest, even though the physician him or herself in fact does not feel conflicted. Finally, the new wording also says that the physician must avoid conflicts of interest. This is very strict wording, but in my opinion more or less aspirational. In reality, it's probably not possible to always entirely avoid any potential conflicts of interest. And the paragraph also goes on to say that where conflicts of interest are unavoidable, they must be declared and properly managed. This wording is another new and important addition to the ICOME. It highlights the need to be open about and address conflicting interests. This is, of course, vital in order to ensure continued trust in the physician and in healthcare. So, the new version of the ICOME addresses conflicts of interest more directly. The term conflict of interest is introduced, and the obligation to recognize, declare, and manage conflicting interests is emphasized. In addition, apart from this general paragraph on conflicts of interest, there is also wording in the section of duties to the patient that once again stresses that the physician must not allow commercial, financial, or other conflicting interests to affect the physician's professional judgment. I will now go on to talk a little bit about another issue that also has bearing on patient and public trust in physician advertising. Many physicians work in private practice. They have their own physician's office and they are their own healthcare provider. Or they might be co-owners of a clinic, a hospital, or of a digital healthcare provider. In any case, they need to make their existence known so that patients know that they exist and that they can come to them when they need to. So the physicians need to advertise in some way. There can, of course, be many different kinds of advertising. Ads in newspapers, posters in public places, digital ads on social media or online, or TV, radio commercials. Some ads can be quite low-key and just provide information about the address of the clinic, the name of the physician or the clinic, and the field of practice. Other advertisements, on the other hand, can be very much in your face with TV commercials and very large posters in public places. They may even show pre- and post-treatment photos of body parts, especially in advertisements for aesthetic treatments. In Sweden, advertisements for physicians, practices, and healthcare providers in general have traditionally been quite low-key. But in recent years, they have started to become maybe not aggressive, but a lot more visible, especially with the establishment of a number of digital healthcare providers that offer physician contact through your computer or your mobile device. Some ads start to look similar to ads for ordinary services and products, and some Swedish physicians have felt quite uncomfortable with this development, because healthcare isn't just another commodity. Like many other national medical associations, the Swedish Medical Association has adopted its own code of ethics for its members. This code is largely influenced by the ICOME. But one difference is that the SMA code of ethics actually includes a paragraph that deals specifically with advertising and marketing. And there is no such paragraph in the current ICOME. Roughly translated, the paragraph in the Swedish code says that the physician should refrain from intrusive marketing. This very short statement is then expanded upon in a separate SMA policy on physician advertising. The purpose is to try to ensure that physician advertising and marketing is carried out in a correct, dignified, and appropriate way, so that the trust in physicians and in healthcare is maintained. But interestingly, as I said, in the current ICOME, there is no specific wording at all on physician advertising. But the working group proposes adding a new paragraph on this issue. The draft new paragraph reads, "The physician must refrain from intrusive or otherwise inappropriate advertising and marketing, and ensure that all information used by them in advertising and marketing is factual and not misleading." The aim of the paragraph is to try to make sure that advertising is carried out in a way that is appropriate, correct, and that fosters and maintains trust in physicians and in healthcare. Healthcare is a very particular kind of activity, not just any kind of service, and this needs to be considered when advertising. So the proposed wording states that physicians must not advertise in an intrusive or otherwise inappropriate way. Intrusive advertising could be, for example, very large posters or persistent pop-up ads on social media or online. Inappropriate advertising could be, for instance, explicit pre- and post-treatment photos of body parts, ads that devalues the work of colleagues, or ads published in improper settings, like websites promoting unscientific methods, for instance. But what is actually to be considered intrusive or inappropriate will need to be decided on a case-to-case basis, depending on the context. However, the paragraph aims to communicate that physicians need to carefully consider how they advertise. The proposed wording also specifically stresses that information used in advertising must be factual and not misleading. Advertisements are usually addressed to the general public or to patients, who often have quite limited knowledge about medical issues. So for this reason, it's especially important that the content of advertisements is not only correct, but also does not mislead the recipient. For example, ads should not promise specific treatment results, or make it seem that a certain kind of care is unique to the advertised clinic when this is not the case, or highlight treatment methods or medical equipment in such a way that it appears that the equipment or the method itself guarantees high quality care. I will now finish by briefly mentioning another issue where there is new wording in the proposed revised ICOME, the physician's ethical obligation to share knowledge. The physician's primary obligation, of course, is to his or her patient. In the context of treating a patient, the physician, of course, has the responsibility to inform the patient about diagnosis, prognosis, and about possible treatment options, so that the patient can provide informed consent to continued care. But outside of this very hands-on and directly patient-related sharing of information, do physicians have responsibilities to share their medical knowledge, to promote health and healthcare? Yes, and this is actually one of the important recent additions to the Declaration of Geneva, the Physician's Pledge. When this declaration was revised in 2017, a new paragraph was added that reads, "I will share my medical knowledge for the benefit of the patient and the advancement of healthcare." So what kind of sharing of knowledge are we talking about here? Well, I think it's about sharing knowledge and experiences that will promote health and help the development of healthcare and healthcare systems. It can be about how to best organize healthcare in order to provide the best care to patients. It can be about addressing social determinants of health. It can be about the need to introduce new treatments in healthcare, or maybe the need to stop using others that are no longer considered good medical practice. Also, it's about helping to explain what medical science, experience, and research shows to patients and the general public, but also to lawmakers, healthcare organizers, and healthcare providers. The pandemic has clearly shown the need for clear and understandable information of what medical science and medical experience shows. I believe physicians have an important role here to share their knowledge and, in doing so, to stand up for science and good medical practice. The current version of the ICOME is not very clear on the issue of sharing knowledge. There is only one paragraph saying that a physician should recognize, or shall recognize, his/her important role in educating the public. The draft new version of the ICOME keeps this paragraph, but rewords it and adds that physicians should ensure that their statements are scientifically accurate and understandable. It also adds that physicians must indicate if their own personal opinions are contrary to evidence-based scientific information. So the need to stand on the side of science and evidence-based information is stressed. In addition, the draft new version of the ICOME adds new wording saying that the physician has a responsibility to contribute to the health and well-being of the populations they serve and society as a whole, including future generations. Furthermore, and finally, the draft adds a new paragraph that echoes the statement in the Declaration of Geneva on sharing medical knowledge. The new paragraph adds, or reads, physicians should share their medical knowledge and expertise for the benefit of patients and the advancement of healthcare and public and global health. So, explicit wording on sharing knowledge is added to the ICOME, and the scope is expanded to public and global health. Thank you very much for listening.
Thank you very much, Thomas. Again, I would like to entertain first 1, 2, or 3 questions to Thomas directly, and then open the discussion for all of it. There is a lady in a blue jacket or pullover, please, if she can have the microphone, please.
Thank you for an excellent and informative talk. So my thought at this point, because I'm from the United States, goes to some of the very controversial practices that have come up, particularly the case now with pharma, with the Purdue Pharma, where this pharmacy is being sued for exploitation of many doctors and very the practices that led to the opioid epidemic in America that they're currently experiencing. It's for $65 billion at the moment. But so therefore, with the pharmaceutical, these are really excellent standards. I see that in the United States, there's a lot necessary for the medical practice to come up to these standards. And I'm wondering also in terms of the pharmaceutical companies, both the United States and the European ones, as well as with the vaccines currently being witnessed, where the vaccine producers are not allowing the vaccines to be produced by those who most need them in the third world. So are some of these questions being extended to the pharmaceutical relationship between the doctors as we're addressing the highest standard, let's say the bioethical standard for medicine as we would envision it, but it has to interact with several of these other medical industries. So I'm just wondering about some of these relationships.
Thank you very much for your question. Well, this policy, this code is directed to physicians, but at the same time, hopefully, it will be a support to physicians in their communication with pharmaceutical companies, with their employers, and with other institutions. These are the standards that we have to live up to. So hopefully that will in some way influence other areas as well. And also there are other policies from the WMA regarding contact with industry. But this policy, the code is supposed to be quite a short but still comprehensive, as Ramin explained, policy addressing obligations of physicians And hopefully, as I said, this will be helpful when physicians encounter situations that they might find trying or difficult to handle. So hopefully this will be some kind of guidance for them as well.
Just the last thought of this, and excuse me, is there a legal body that allows people within states, within nations, the doctors or the patients, to access the international standards beyond their national standards? What's that relationship?
I'm not entirely sure what you mean, but this policy and the ethical policies are not legally binding. So these are guidelines, but they have been developed, and that is, I think, one of the main strengths of the WMA is it's a truly global organization. As we heard, 15 national medical associations are members. So by having this global scope, hopefully this will have some impact internationally, but these are not legal documents. These are policies, ethical policies.
Thank you very much.
The gentleman over here, can we have a microphone there?
Yeah, hello. Very good surprise to see this this text. I totally agree with the idea to share the medical knowledge for the benefit of the patient and, of course, the advancement of healthcare. Very good idea to have this scientifically accurate, evidence-based info. But now we know that technically the biggest problem at the moment is the fact that all health data is not available for the patients and not available for the scientists. So I know it's not directly a question for ethics and more a technical question, but if you want really this to be applied and to have evidence-based info really available, you have to have rules or at least proposals concerning how it is going to work to share the health data. Mm-hmm. For example, in my country, in Belgium, we have one legal place or one, let's say, one online place where citizens can share the health data, but at the moment we cannot share with scientists and we cannot share with other people.
No, thank you very much. I understand. It's, of course, this policy deals with the knowledge that you as a physician have, that you should share that in the arenas where it's possible for you and with the basic scientific basis that you have access to. But of course, what you're talking about is a little bit separate issue, but naturally, if we do have information but it's not widely available, that might be a problem. But the last words you said seemed to indicate that there was also, or understood that it meant also personal data from individual patients, and then we get into a whole different area of problems. So we might do that because of
maybe there could be at least one obligation, concrete, for the medical doctors that the information of their own patients is really electronically available to the patients. For example, it could be something that very concrete, but an ethical principle.
Yeah, that is not something that is addressed in this policy of core obligations for physicians. This is really even though the issue of conscientious objections that we discussed earlier is a little bit on the border, because it also talks about the rights of physicians to decline some treatments. But otherwise, in general, this policy, International Code of Medical Ethics, is a document of obligations for physicians.
But if I understand you correctly, you think that the provision of data in an electronic format and making it available, for instance, for the patient, him or herself, is an obligation of physicians. I would personally see this under the obligation to document and to accept the ownership of the data with the patient. So the patient owns his own data. And of course, he can ask for this data. And I think would find it very natural that in a development of healthcare system and the digitization of nations, of our environments, this transforms from the right to get a paper record from your doctor about your decision to an electronic one. But I think for that, first of all, your infrastructure has to be correct, the infrastructure has to be safe, and it has to be feasible for everybody to do that before we could say you have to do that in an electronic form. But I agree with you, there is the obligation to provide the data, and I think it's a matter of time and a matter of infrastructure that this will be done electronically and in a way that a patient can use that. Most of the healthcare systems I know are in a process of trying to do that. There is no perfect example so far that I see where you can say all the preconditions are met for doing this in a perfect way. But I think we are clearly on the way to that. In addition, I would like to point to the Declaration of Taipei, which separates the question of ownership of data by a patient and in the context of treatment from the use of data for other purposes, like for instance for research. And there is a very clear guideline on how physicians should behave and what they should do and how they should work in this sphere in order to provide, for instance, data for research from patients collected as a physician there. However, this sentence which Thomas has been given here is really about I share my medical knowledge in general with my colleagues, for instance, with science. I teach, I share this with young students, which is important. And why is it so important to have that in an ethical document? It is because more and more healthcare companies treat this knowledge as a secret. And they don't want you to share. They don't want you to share with other doctors. They don't want to share with the general public on how to best treat a patient because they see this as a commercial advantage. And therefore, for us, it was important to bring this into a document, an ethical document, to tell it is your obligation to share knowledge and to reach out, to publish, to teach, to talk to your patients. That is the important point here. It was not about the individual patient data, which in this context, for me, is standing under proper documentation and the ownership of the data, the health data of the individual patient with the individual patient. Any more questions to Thomas or to Ramin? Perhaps in the meantime, another sentence to the question that came up earlier to the questions of disasters, emergencies, and pandemics. We have been working on this field for many years now, actually for the last 15, 16, 17 years actually, after the SARS crisis. And we have developed a whole array of policies on disasters and emergencies, which we are currently, under the impression of the COVID-19 pandemic, are revising in order to see what was right, what was wrong. Unfortunately, I can tell you, most of the things have been foreseen in these pandemics, so we have described what can happen, and it happened. It may be with us, and this may be our guilt, that we did not advocate these policies good enough, because there were a lot of warnings in there, a lot of advice. Would it have been followed, we would have saved a lot of lives during this pandemic and a lot of problems during this pandemic. So this is certainly something which falls on us, that we have to better advocate with politicians, with general societies in pandemic preparedness. There is another area which is like the pandemic preparedness and the disaster preparedness important, that, for instance, is medical care and medical ethics during wartime. This is another area for which we have developed policies since 1956, which we now have put on a new platform together with other health professions like the nurses, physiotherapists, pharmacists, together with the International Committee of the Red Cross, together with the International Committee of Military Medicine. So we are dealing on this. But the idea of the International Code of Medicine is, of course, to cover all situations and not to go into a specific situation, not to be into a specific situation of medicine and not to go into a specific group of patients, for instance. Some of our colleagues said, well, why don't we include children here? And then somebody else would say, okay, then we also have to talk about old people. So what we want to have with the Declaration of Geneva and with the International Code of Medicine, we want to have the umbrella for those. But yes, you are correct. The pandemic situation, the disaster situation, emergency situation needs specific policies and need to be specifically addressed. And the same is true for other areas like, for instance, medicine in times of conflict. If you have no more questions to us, there is one more, and let's take that, but then we will have to conclude because we are already a little bit over time. Please, the gentleman over there.
Yeah, I will just provide a few sort of very quick lines, and then in case we can talk about it during the break. I wanted to specify a little bit what I said about, and I agree with the expression that it should be all sort of disaster situation. We are not necessarily talking about a special chapter to be added to the WMA code. On that, I can accept that, but maybe there might be a different kind of declaration. Where we had a lot of problems during the pandemic, and when we actually lost lives, was actually in that mechanism of coordination between the ethics in non-pandemic and non-exceptional times, and how you pass and when you transition to a different sort of ethics. So that's probably a transition and a relationship, a coordination that needs to be made clearer. Also, when we are talking about the COVID-19 pandemic, we are not anymore in a disaster medicine scenario. That's actually the medicine we are dealing with. Triage decisions, waiting lists will not be dealt with in the same way that they used to be dealt with before the pandemic. Consent to treatment for vaccination, especially in low and middle income countries, will not be dealt with in the same way in which was dealt with before. A third consideration, and I close, the drafting technique is not a secondary problem in this case. One of the huge problems that you touched was very on point. One of the problems is that during the pandemic that the rules were there, the criteria were there, but were definitely not properly understood because they weren't in the same place.
Yeah.
The proliferation of ethical declaration is the ethical declaration have boomed in the last year, and rightly so. So also considering a chapter that summarizes the main issues that are maybe put somewhere else in one chapter will actually help the medical profession, and not only the medical profession, to focus on what they have to do in situations of huge stress.
Thank you very much. I think it's a very important comment, and I would like to take this on board and back home. However, the idea is, and let me make that also very clearly, the idea is of the international code is really to be valid in all times. So regardless whether you have a war situation or yes, but the understanding is that you said we switch to another ethics. That is not what we have in mind. What we have in mind is that there are certainly different circumstances, which also sometimes may come to different results, which we have, but that the principles are being maintained, and those we would like to embed in there. And I think we all have done during the time now of the pandemic even more in depth to consider what does it mean in a situation when you are in, for instance, in an armed conflict or in a pandemic situation when suddenly nothing works anymore, that doctors are ill themselves, that treatments are no longer available, that patients are dying in masses with that. So that is certainly something that yes, we have to keep in mind, and maybe we have to reiterate once more under the aspect of have we covered this and have we led to our specific policies which we have to in order to deal with those specific situations a little bit more. They are not only ethical, they are sometimes also technical because it has different technical aspects. Thank you very much for a very interesting discussions. Thanks to the presenters, Thomas and Ramin, for your preparedness to be here, and thank you very much for your interest and for your discussion. Please stay tuned to our work. I think we will go to more open discussions with you as ethics experts, with the general public, with patients, and we would like to invite all of you then to contribute and to send us in your observations, your remarks, your suggestions for that. Not everything will be taken in, that's very clear, because a lot of things may be contradictory to each other. But what we have seen in the past, and also with the fora which we had here in this conference, we always got very meaningful input, very, very serious input to that, which the group, the drafting group has really then seen, has taken account of, and has considered with that. And many of those proposals have been extremely helpful to us. So please stay tuned to the work of the World Medical Association. It is important to us, and it has a meaning for us. Thank you very much.